Right, can I ask Professor Stevens to come to the podium? All yours. Thank you.
Well, thank you very much for all of you coming. I guess this is a late start for orthopedic surgeons, so it doesn't seem so early. I'd particularly like to thank Mr. Shinoda Shalaby, thank you very much, Mamdouh Morgan, and Colin Howie for inviting me. My name is Terence Stephenson, I'm chair of the GMC, so I'm normally responsible for 267,000 doctors on the UK Medical Register. I just want to start by saying something about one of them. That's me. I'm one of you. I'm one of those 267,000 people. The GMC, sometimes viewed as a rather distant body based in London, but I walk the walk. Last month I was responsible for the resuscitation of a 7-year-old child in asystole. And so I'm still a practicing doctor like you. I do outpatients, I see emergencies. And like you've been hearing from colleagues, I, every 4 years, have to pass a resuscitation course, and I have to do it with the trainees, and there's no special pleading. And I failed one of the stations, and I'm the person sat on the naughty chair when all the trainees pass through. I have to be willing to walk that walk, because if I don't do the resuscitation training, and I'm managing an asystole in a child, then I'm not properly trained. And I revalidated in 2013 until 2018, so I've done that as well. There's no special pleading for me. I have to go exactly through the same process as every other doctor in this country. Of those 267,000 doctors, we have data that suggests that about 20% are neither trainees, they're not on the specialist register for any hospital specialist, and they're not on the GP register. We don't actually collect data on whether they are SAS doctors, but let's assume that 20% are mostly made up of a mixture of SAS doctors, trust doctors, that kind. We do have good data on them. 2/3 of them are IMGs, there's no question about that, international medical graduates. But we should never discount that about 1/4 to 1/3 are UK graduates. So I made a slight mistake with Shinoda, kind of, as probably many people do, of thinking that SAS doctor is synonymous with international medical graduate. Not true. Perhaps 10 to 15% now coming from Europe, but 1/4 to 1/3 are United Kingdom graduates. And I also walk that walk. One of my best colleagues I work with is an SAS doctor, an asylum seeker from Iraq. She is the doctor. If my child was ill, I would actually want my child to be looked after by. She's extraordinarily experienced and competent. And I helped her get, I'm a pediatrician, so I helped her get the membership of my college exam because she seemed really stuck by giving her extra training. So I do really value my own SAS colleagues in my workplace. And I draw out the fact that 2/3 of SAS doctors are IMG just to highlight the fact that as Colin Howie made the point very eloquently, the NHS is very dependent on non-UK graduates. Make no mistake about that. If you take those 267,000, 40% of doctors practicing in the UK today did not graduate in the United Kingdom. And the NHS and the British public are very, very dependent on, at the moment anyway, the future may be different, very dependent on international medical graduates. So that's a bit of background. The GMC was formed in 1858, surprise, surprise, against great resistance from the medical profession, who tend to resist everything really, very conservative organisation. It was driven not by doctors, it was driven by Thomas Wakeley, who was a very radical campaigning first editor of the Lancet, and there were 11 attempts in Parliament by MPs to bring forward an act that would allow the British public to distinguish who is a proper doctor and who is a quack, who's a bone setter, who's an apothecary, who's a herbalist. So it was really an idea to set out. And once that 1858 Act came in place, with it came 4 duties that endure to this very day. There's 4 things the GMC do. Once you have an act that says these are doctors and all the rest aren't, there's 4 things. One is you have to keep the register of who is a doctor and who isn't. That was the 1858 Medical Act. But that leads to the other 3 bits. How should you educate and train people to get on, to be doctors on the register, so we can have complete overview of all undergraduate medical education in the 30 UK medical schools and all postgraduate medical education delivered by the colleges. That's education training. The third responsibility, you've got the register, education training, how do you get on it and stay on it. Third is providing guidance for how doctors should behave and to help them in their careers. We provide lots of guidance on consent, on mental capacity, on whether you should report to the DVLA if someone who drives has had an epileptic seizure, just huge amounts of guidance to help you in your practice. And of course the fourth element is when should people come off that register, and that's the fitness to practice, which is the bit of the GMC that everybody knows most about and fears most greatly. And I have also had personal experience of that. I've walked that walk. I've been reported to the GMC twice personally, once by another doctor, once by a patient or parent for working in child abuse, quite a fraught area where you're quite vulnerable. And so I've been under that sort of Damocles personally for 2 years twice. And so you don't need to tell me how stressful and difficult that is as a doctor, but I'll say a bit more about that. I'm afraid it's an occupational hazard, really. Okay, so that's what the GMC was set up to do. 150 years on, those four things are what we do. I want to use an illustration for SAS doctors of each of those four bits of what we do and why it's absolutely relevant to you. So let me just start. I want to leave fitness to practice to the end because it's what everyone focuses on. Let me just start with the education and training. So first of all, we are as concerned as I'm sure you are about worries about differential attainment of BME doctors in the UK in both our college exams and concerns about potential discrimination on the basis of skin colour or accent, and a concern that the PLAB exam that IMG doctors have to do to get into this country is somehow not comparable to what UK graduates have to face. So I'd like to introduce a UK medical licensing assessment. I'm delighted to declare CSER, David Lim mentioned it. So David Greenaway thought CSER should remain. NHS Wales and NHS Scotland have been empowered with taking forward a specific work stream of the shape of training for SAS doctors. They haven't reported yet, there's nothing I can tell you about that, but they're working on it. David mentioned the GMC has improved its guidance, and I said that one of our four roles was better guidance for doctors to help them in their career. We've improved our guidance on how to complete CSER. You've had some tips today, and there's also an equivalence advisory group being set up to help. I thought David was incredibly modest for an orthopaedic surgeon, an unusual quality in my experience of orthopaedic surgeons. He said it was all the GMC, but of course the GMC has really no specialist skills, but generic skills. We are totally dependent on our expert colleagues in colleges, in craft specialties and other specialties, physicians, orthopaedic surgeons, psychiatrists. They really help us judge whether that person's application is truly equivalent. So yes, of course it's true, as David said, the GMC makes the final decision, but it's hugely dependent on the expertise of those two advisors, so it's a partnership. Okay, so I mentioned two of our roles, education and training, and the fact that we provide guidance. Thirdly, the register, we still keep that register of all people who are entitled to call themselves doctors, and we have added an idea that you can be on the register, and that's separate from having a license to practice. And to keep your license to practice, you have to revalidate it, and that applies to all doctors who want to have a license. So there's being on the register, 267,000, then there's the specialist register for physicians, orthopedic surgeons, pediatricians, and there's the GP register. But if you want a license to practice, you have to revalidate. And that's a good news story for SAS doctors. The appraisal rate for SAS doctors has gone up from 35% to 78% in 2 years. Why do I think that's important? Because I'm a great fan of appraisal, and it predates revalidation by a decade. In my university, appraisal was introduced probably 15 years ago, and then introduced by my NHS Trust. And it seems to me axiomatic that if you're paying people £70,000 a year, £100,000 a year, as a minimum, you would expect to sit down with them for an hour once a year and find out what they've been doing for the last year and what their plans are for the next year. So I've been a huge fan of appraisal, both for myself, I get a lot from it, and appraising others. And the fact that SAS doctors' appraisal rates have more than doubled in 2 years means that your employers and your clinical director are taking SAS doctors more seriously. Whether they want to or not, the fact is they have to. It's a core part of revalidation. That gives you an in for some of the things that were being talked about in the last two talks about fellowships. It's part of appraisal. Key part of appraisal is you have a personal development plan, a PDP. You should write what you think your PDP needs are before your appraisal. It must be discussed in the appraisal, and at the end of it there should be some agreement in the sign-off of your appraisal of what's going forward. Everybody is entitled to a personal development plan, including me. I'm 57, I'm not a trainee, I still have needs. Each year in appraisal, I still have a personal development plan. You should have the same. You should be asking for that. It doesn't mean you can just say, my PDP is I'm going to Seattle. Of course, that's not how it works. It's a negotiation. It has to be grounded in some realism. It has to be doable and affordable. But it doesn't mean that people are just stuck forever doing nothing. Everyone has a personal development plan. And then finally, the fitness to practice chestnut. So let's put this in perspective. 267,000 doctors on the register. How many complaints, have a guess, how many complaints do you think we get about doctors a year at GMC? Have a guess. 3,000? Anybody else? 5,000? 25,000? 10,000? 10,000 complaints a year. We don't engender those. Don't blame the GMC. Under the 1983 Medical Act, we have absolutely no latitude. We have to investigate every single complaint that comes to us. 10,000. How many people do you think are struck off a year in the United Kingdom? Of that, the 267,000 on the register, how many think get removed from the register? 50? Good guess. 55 last year. So we have 267,000 doctors, 10,000 complaints. At the end of it, 55 people get struck off. So whilst fitness to practice is a huge thing, and I said I've been under it, let's keep it in perspective. Most doctors, all of you in this room, don't get up in the morning expecting to go to work and harm someone. You would rather not have a complaint. It's an occupational hazard. Over a lifetime, there's quite a high risk of you being complained about to the GMC. About a third of those complaints are from patients, about a third from fellow doctors, about a third from employers. It's going to happen, but most of them don't lead. About 5,000 of them we chuck out almost straight away once we start investigating them. They have no merit. Another 1,500 go back to the employer because there is an issue, but it's a contractual issue. Somebody's not turning out for their sessions, say. It's not really a fitness to practice issue. When they are there, their practice is fine. They're just not fulfilling their contract. And then there's a number that go through a fitness to practice, and as I say, 55 end up being struck off. So the good news is, SAS doctors are less likely to be complained about than people like me or Colin Howie. In fact, you're about half as likely to be complained about over any 4-year period that we look at. We've got very good data. You get far less complaints. It's good news. It may reflect the fact that you're better doctors than me. I don't really know the reasons why. It may be that as Mamdouh was hinting at, it's not your name on the bed, the accountable clinician, or not your name on the operating. I don't really know the reason, but anyway, good news, half as likely to be complained about. Bad news, if you do get complained about, I'm afraid twice as likely to have a sanction against you, which is something that concerns me, and we are investigating why that might be. But there are some plausible reasons why you might be more likely to have a sanction against you. One of which is the group of people most likely to do badly when they complain about the GMC is the people in this room, actually, I'm afraid, apart from Claire, including me. It's men over 50. That doesn't matter whether you're white or BME or a UK graduate or an IMG. It suggests either we're getting out of practice, or we start to believe our own bullshit, or we have we've been doing it for a long time, and we become less sensitive to the fact we might be getting stuff wrong, less attuned to, we have too much hubris, we're not listening to our trainees and our nurses. Anyway, it's middle-aged men, and middle-aged men, more than middle-aged, are most vulnerable, so that may be the reason. Anyway, I'm going to stop there. I'm very happy to take any questions, as I'm sure anyone else is. I just want to finish by saying the very fact that this meeting is happening and that Colin Howie, Claire Marks and I are here, I think says a signal, a very clear signal, that all of these bodies, the Royal College of Surgeons of England, the BOA and the GMC, take SAS doctors and their issues very seriously. We're very interested to hear your views, and you're a very important part of the fabric of the NHS. So again, thank you for coming to hear me. Thank you.